Good evening, I'm Maria Muro. Welcome back to our show. Tonight our topic is spinal disorders and minimally invasive spine surgery. My guest is Dr. Marco Rodriguez. He's a local orthopedic spine surgeon at the International Spine Institute located right here in New Orleans. Dr. Rodriguez obtained his medical degree from Case Western Reserve University School of Medicine, followed by his residency at Louisiana State University. He completed his fellowship at the Texas Back Institute and is board certified by the American Board of Orthopedic Surgery. And we're excited to have you on the show, Dr. Rodriguez.
Thanks for having me.
I know. I'm really happy you're here because, you know, this is a really great topic and that affects many, many people. But before we start talking about, you know, spinal disorders and treatment options, you know, we'd like to learn a little bit about the physicians. So why did you choose this field of medicine?
Well, I think in spine surgery can make a dramatic change in people's lives. I remember during medical school, a guy I met in the clinic, and he was in horrible pain, buckled over, couldn't stand up. I went the next day with the surgeon to do the surgery. I went the next morning at 5 a.m. to find him, to round on him, and he was walking the halls with no pain. I said, if I can change someone's life that much, that's what I want.
I love it. I think it's exciting. And you know, when it comes to spine surgery and all of the different treatment options, you know, of 20 years ago versus today, you know, what are your thoughts on that? There's obviously been a lot of advancements.
Yeah, you know, that's the thing I run into a lot with patients say, well, my uncle or my grandfather had surgery and they've been disabled forever, and it's just another world. And one thing that's really helped us a lot is minimally invasive spine surgery. And it's a general term, but the idea is much smaller incisions, less trauma to the muscles, and really just doing what you need to do without damaging everything along the way.
Absolutely. Well, when it comes to back surgery, my dad, many years ago, maybe about 20 years ago, actually had back surgery. I remember the entire family being just terrified.
Yes.
You know, that whole thought, you're going to be paralyzed, you're not going to make it out. It was just very, very intimidating. So how do you deal with patients, you know, when you consult with them, you know, alleviating some of that fear?
Yeah, I mean, I think it's that idea of putting in context. When the one thing is in the low back, you're not working around the spinal cord. So that already eliminates paralysis because there's no spinal cord to injure. In the cervical spine, that is a real risk, but the risk is extremely low, and I think it's a matter of communicating the real numbers. Another thing that's helped us a lot was live nerve monitoring. So we watch the nerves during the surgery to make sure we're not causing damage. Okay.
I also want everyone to know that if you have a question for Dr. Rodriguez, feel free to call. It is 866-3200. We'd love to hear from you. All right. So let's talk about your practice, Dr. Rodriguez. Tell me about, you know, your patient base and a little bit more about what you do.
Yeah. So I moved back to New Orleans about 1.5 years ago and really focused my practice on treating the spine with the least amount of damage as possible.
Okay.
So keeping the motion, some motion sparing devices, artificial disc replacement is a common one, minimizing the trauma, so minimally invasive spine surgery, and a special interest is endoscopic spine surgery, where we're using cameras to look at the spine, and through 7-8 millimeter incisions, we can do what in the past took us, you know, incisions all the way up the back. So it's really changed the way we treat the spine. And so that's where I really have my focus. Another area that's very promising is what's called regenerative medicine, where we're essentially taking stem cells from your own body and putting them in the spine to help it heal, rather than just treating it when it's damaged.
Okay, is this a relatively new procedure?
This is something that's very new, and it's in the early stages, and it's very promising.
I love it. Well, you have a prop here. Let's talk about the spine, doctor, and explain to us, you know, the anatomy of the spine.
Yeah, so this is looking at the spine from the front. Essentially what you can see are the bones in white. In between the yellow portion is the discs. So in between each of the bones of the spine are vertebra or disc or shock absorbers, and these allow us to take force when we bend forward and back. There's joints in the back of the spine called facet joints, where the bones meet in the back, and these are very similar to knees or shoulder joints that have cartilage and glide, as opposed to the shock absorbers in the front. This all is made, these are all is made to protect these nerves, which exit the spine and go down the legs. So same idea in the neck, they exit the spine and go down the arms. And they're protecting the spinal cord throughout.
Okay. Thank you so much. All right, so let's start discussing some of the most common conditions that that you see patients for.
Yeah, so the most common conditions we treat are disc problems. So the discs tend to degenerate in a very consistent pattern. So they start to dry out, then they get cracks in the disc, and then the gel portion in the middle of the disc can push out of the disc, push on the nerves, causing sciatica or radiculopathy or radiating pain down the legs and arms.
Okay. And arthritis. Let's talk about arthritis and how it affects the spine.
Yeah, so arthritis generally is a general term for inflammation of the joints.
Okay.
In the spine, that generally gets put together with degenerative disc disease. So the facet joints, which again on the back of the spine, are more of an arthritis situation. The disc is degenerative disc disease, but the combination of all that is just essentially aging of the spine. A mentor of mine used to call it gray hair of the spine.
Okay. So typically it's older people who would develop this.
It is. I mean, some people start at an early age, and it usually has to do with family and genetics.
Okay. So when you say genetics, please explain that a little more.
Yeah, it's not a specific gene like some areas of medicine,
right.
but you definitely see a family trend. When the parents have degenerative disc disease, the children have a much higher risk of developing that at an earlier age.
Okay. And what about osteoporosis? How does that play in
So
all of this?
osteoporosis is really another area as far as the generation process, but osteoporosis is the density of the bone. So the spine, the vertebra of the spine can collapse or crack or fracture because they don't have as much density. Now that's different than the disc or facet arthritis.
Okay. All right. And what about cervical radiculopathy or a pinched nerve? I know, we kind of hear that term a lot. Oh, I think I have a pinched nerve, but do we really have a pinched nerve, or is it something else?
Right.
So what is it?
So the pinched nerve, a pinched nerve is not a pinch in the back of the neck. It's really a pinching of the nerve and causing radiating shooting pain down the arms or legs.
How does that happen?
So the ways it can happen are either overgrowth of the arthritic joints, which narrow the space for those nerves, or a herniation or protrusion of that disc material pushing on the nerve.
Okay. And so when it comes to the pinched nerve, how does one develop it?
Yeah, so
what causes it?
So this can be a natural progression of degeneration of the spine and a single event that may progress that over the top, or a significant traumatic event like a car accident or a fall from a height.
Okay. And so now what are the typical symptoms associated with it besides that leg pain?
Right. So the pinched nerve, not only can you have radiating leg pain, but because you're pinching that nerve, it doesn't function correctly. So you can develop weakness or numbness in the portion of the leg that nerve serves.
Okay. And a common term that we also hear a lot of is somebody who throws their back. Have you had patients, I threw my back.
Right.
What is that actually came through on Facebook as well with our wonderful questions right here.
Sure,
Doctor, I threw my back. Why does that happen?
Yeah, throwing the back out. I mean, this is theoretically in my mind that basically if you have a tear in the rim of the disc, it can progress, or you can strain the ligaments. I think a ligament or muscle strain is the most common thing that people have, but when you have degeneration of the spine or some type of pathology in the spine, it predisposes you to those type of injuries.
Okay, very good. All right, let's go to our next topic, which is disc herniation. What is a disc herniation, doctor?
Sure, disc herniation. So this is a general term for that shock absorber that in the front of the spine for it pushing backward toward the nerves. So the herniations can come in a lot of forms. They can come in a bulge, which is more wide and spread throughout the disc, or it can be a protrusion where you get a crack in the disc and the gel in the middle pushes out through an area, or an extrusion where that gel actually spits out all the way.
Okay, and so now what are the symptoms of a herniated disc?
So herniated disc can cause back pain because there's nerves around those discs, and there's a huge inflammatory reaction. So your body essentially goes to fix that problem, and that causes a lot of swelling in the area, a lot of local pain. In addition to that, when it compresses the nerve or those chemicals affect the nerve, it can cause shooting pain down the legs, weakness, numbness, and in horrible situations, sometimes even the ability to control your bowel and bladder function.
Really? Okay. Yes. And so what causes this?
So degenerative discs, herniated disc can come in a lot of forms. I mean, again, it can be just a natural aging process or a traumatic event through a tear in that disc.
What about prolonged sitting? Because I know someone wrote, we got this other question right here. Hold on a moment. Little gentleman wrote, hold on just a moment. When I sit for many hours, dear doctor, I have sharp pain down my leg. Why is this happening and can this be prevented?
Right. So the biomechanics of the spine, when you sit, you actually put more force on the disc. When you stand, you put more force on the facet joints because you lean back just a little bit. When you sit, you lean forward a little bit. So one thing that can help this person with their pain is a better posture. So it's lumbar support that it causes you to extend the back a little bit. Positioning your seat so your legs are more supported,
Okay.
sometimes putting them up on something
Okay.
can take stress off of that disc. And then the other thing is getting up and standing and walking around because you're not putting as much force on the disc.
Okay. And now, how do you diagnose it? And what are the tests involved?
Yeah, so the most important thing for diagnosis is a history, talking to a patient.
Okay. Tell me about that consultation.
Yeah, so the first thing you really want to know is, where do you hurt? How long have you hurt? And then what other symptoms come with it? Weakness, numbness, tingling. What things make those symptoms come about? Once you know what the symptoms are, you want to know how they've treated this problem. So, going through that question process. And then once you have an idea of where that pain may be, use physical exam to check the nerves to see if you can recreate the pain symptoms to better define where that pain's coming from. And then with all that story, you really want to confirm that with x-rays, which look at the bones, and MRI scans, which look at the discs or the nerves.
Okay. And once you've diagnosed it and it is a herniated disc, let's talk about the treatment options. Okay. So I know there's conservative approaches and less conservative.
Right. So the term, conservative essentially, obviously, if we're not putting anything in your body.
Okay.
Right. So the most conservative thing is observation. We know 90% of the time discs get better on their own. If we just give them some time. Now, sometimes it can take 3-4 months to get better. And the idea is during that time period, what can we do to help the symptoms? So medications, anti-inflammatories, Advil, Aleve over the counter, there's prescription versions. If those aren't effective, sometimes narcotic medicines may be used temporarily, muscle relaxers. And beyond the medications, if that's not enough, physical therapy can accelerate recovery, chiropractic adjustments can help.
Okay.
So that all fits into that conservative mode, and there's a lot of other things that are out there as options. Acupuncture, and really physical activity, yoga can be very beneficial in this situation.
We have a caller for you. We have Thelma on the line. Good evening. What is your question for Dr. Rodriguez?
Hi. I've done like all the injections and the epidural and different ones. Are you there?
Yeah, we hear you,
Yes.
Thelma. Can you just repeat that? So your question is, you've done those different, doctor? You want to talk to Thelma?
Yeah, so you've had epidural steroid injections. You're asking what's your next option?
Oh, I was just stating that I've already had all the injections in my back, and nothing has done anything. I mean, like totally zero. But I got the sciatica going on in my left side. And I was really, and I guess arthritis too in my lower back, but I was really interested in that stem cell.
Yeah, so the real
work.
value
And
with
if
stem cells currently is to heal tears in the discs. So the back pain that comes from the tears in discs is something that's very difficult to treat with small surgeries, and generally requires a fusion or an artificial disc replacement, which is more major. But with the stem cell treatments, you can actually heal those tears. So with sciatica per se, it's probably not something that's going to benefit from stem cells right now. Probably what you're looking at is something where you may need to remove some of the bone or disc material. And again, it's not a major surgery necessarily like it was in the past. You can put a camera in through a less than centimeter incision and remove some of that bone and disc material to take that pain away down the legs.
Thank you, Thelma. That was a great question.
Yeah.
Great question. And so do you have patients who are in this, situation where they've had all of the injections and then, it just, they still haven't, I guess they're still in pain. What do you do then, doctor?
Sure. So, there are a lot of options. So one thing you have to understand is all spine surgery, most spine surgery is elective. The things that make us progress towards surgery, severe spinal cord compression, causing an inability to use your arms and legs, progressive weakness, loss of control of your ability to control your bowel and bladder. Aside from that, it's something that really can be treated by watching it. Okay, if you can live with the pain, you can live with it. Now, when the person reaches the point where they cannot function or do the things they want to do, then we offer surgical options. But surgery comes in a lot of different forms.
Okay, so let's talk about that. We have 10 minutes left, and we're going to talk all about minimally invasive surgery because I know you're passionate about that.
Yeah.
So, minimally invasive surgery, what is the difference between that and, for instance, the different procedures you discussed?
So traditional surgery goes through more of a midline incision in the back. You spread the muscles apart to get down to the bones and discs and the nerves. Well, what we've developed over time is actually making smaller incisions, 2 centimeters or less, looking down to the spine with tubes or cameras, and then removing the disc or bone material that are compressing the nerves. And even spinal fusion, which again in the past was a much bigger surgery. I mean, even as far as casting and bed rest, now we do it through 2 or 3 centimeter incisions. People go home the next day. Traditional surgery is up to a week in the hospital. So it's really a different animal.
Okay, and now I want to show this animation that that you gave us, Doctor. Talk about this procedure that we're about to see, and what is it, and who needs this type of procedure.
Sure.
All right, so go ahead.
This is describing endoscopic rhizotomy, which is a procedure to basically burn or kill little nerve branches to the arthritic joints in the low back. So the back pain that comes from those joints can be stopped by killing the nerve so you don't feel the pain. This can be done through 2 small, less than 1 centimeter incisions and go home the same day.
Okay, so now what type of conditions, what type of conditions would benefit from a rhizotomy?
So the low back pain that comes from the facet joint arthritis. So back pain that generally is worse when you stand or lean backward generally responds well to this. And what we do is we do a test shot to actually numb that little nerve branch.
Okay.
And you see how you feel during that time period. When it's numb, if you feel great, then we know if we go kill that nerve, we can recreate that feeling.
That's fantastic. Okay, so now let's talk about the other type of surgical options that that you perform.
So with the camera, the endoscopic rhizotomy is a great option. Also with the camera, you can go and you remove part of the disc. So discectomy, an endoscopic discectomy, can be an outpatient procedure, 2 weeks of recovery. So really progressive for where we want to move with healing people quickly and getting them back to work and back to their lives.
Okay.
If discectomy and or rhizotomy through a scope is not enough, then we can make slightly bigger incisions, maybe 1.5 centimeters, and using tubes, we can look with microscopes or special glasses to look at these structures and remove any pressure on the nerves. And then finally, the bigger procedures, again through 2.5 centimeter to 3 centimeter incisions, we can fuse the spine together. Another thing that's really close to my heart is artificial disc replacement, which what this does is actually replace the poorly functioning disc and put a mechanical device in that moves. So in the past, people used to fuse knees and hips and shoulders to heal the pain. But over time, we developed replacements like total knee replacements and hip replacements, and then the spine has followed along with the disc replacement. And I think that's a really, it's a promising area and something we've been doing the last 15, 20 years in this country, but slowly is becoming much more common.
Okay, and what about the patients? Have they been very satisfied with the outcome?
Oh, excellent. You know, most patients, in most patients, we can get rid of almost all their nerve pain.
Okay.
The back pain is a much more difficult area to treat. But the idea is to minimize the amount of trauma to maximize the benefit. But on average, we get rid of 50% of back pain, but in some patients, 90% or 100%.
That's wonderful. We have another caller for you. We have Agnes. How are you, Agnes?
I'm fine. I wanted to ask the doctor, I had a rhizotomy in 2013, and I have also had the epidurals in 2015. And I had some improvement with that. But I do have I had a discectomy from an automobile accident at L4, L5. And I now have trouble at the L5, S1 level, which is why I had the epidural injections with some improvement. But I am having some loss of function in my right leg. And I also have bulging disc above L4 and L5 on the left side, as well as on the right side. So, what is there a way for me to have a cement type substance put in my back, or am I stuck having to have rods put in my back?
So there's a lot of, so the question for me is, what are you trying to treat? So if it's the nerve problem or the pain down the legs, the cement's not going to treat the problem. The cement's really more directed at a fracture or a broken bone in the spine. The cement really would not help in this situation. Really what you're looking at is taking pressure off the nerves if it's not functioning properly. The other thing you got to realize is with the rhizotomy, so if it's a back pain issue, the traditional rhizotomy is done with a needle percutaneously with a live x-ray, but you're not looking right at that nerve. So that procedure normally gives you about a year to year and a half of pain relief. With a camera, we've seen 85% back pain relief at 5 years after that procedure. So it's a much more long-term procedure because we look at that nerve, we pull it apart so it doesn't, hopefully does not return at all.
That was a great question, Agnes. And if you want Dr. Rodriguez's information, we'll have it at the end of the show. All right, so we have a couple of minutes left, Doctor. What are the biggest advantages of minimally invasive spine surgery? Is it the downtime? What is it?
So the most obvious advantage is less pain and quicker recovery. We know that when we make smaller incisions, we lose less blood, people have less pain, and they go home faster. They get back to their lives much faster. So that is the most attractive thing. But as we've looked over this over time, we're starting to see that the collateral damage of more traditional open surgery is causing secondary issues. So the scar tissue and all the muscles around the spine, when you pull all that muscle off of the spine, it never quite gets back to where it was. So the strength in those muscles are not there. I've been back into spines that have had minimally invasive spine surgery, and I can't find where the prior surgery was often because you cause so little damage in the process.
Okay. And then what can someone expect after the surgery? Do they go home the same day? What's the recovery period like?
So generally patients, I leave it up to them as far as their symptoms, but you can leave home the same day, several hours after surgery with a smaller procedure, laminectomy, removing some of the bone or disc material.
Okay.
With a spinal fusion, which is traditionally the bigger surgery, the screws and rods, my patients go home the next day. So I think even in that situation, most of this recovery is at home.
Okay, we have another caller for you. Good evening. What is your question for Dr. Rodriguez? Oh, she's not ready. You'll come back to us. Okay, this is definitely an exciting topic, and I think that, the fact that we have callers or viewers who are, again, a lot of us are intimidated by back surgery, and the fact that this wonderful animation that showed those very small incisions, I think is great. And you also have some younger patients that you've treated, Doctor?
Oh, yeah.
Like some athletes who obviously have a lot of wear and tear. And
Sure. So young people are a different animal. I mean, the one thing is they have very high expectations of returning to high levels of function.
Okay.
So athletes specifically, you have to sometimes limit them, especially with these minimally invasive procedures, because after doing an endoscopic discectomy, your pain is gone in a couple weeks. So they want to get back to those activities right away. But the danger is the trauma, the procedure that's been done weakens the disc slightly for about a month afterwards. So you really have to slow them down. So that's an interesting animal with young people. And then you have to really teach them good mechanics. I mean, when we're young, we don't bend our knees when we pick things up.
Right.
We jump off of whatever, and we don't watch what we do, right?
Yes, we do. We have one last caller for you. We have Cynthia. Good evening. What is your question for Dr. Rodriguez?
Hi.
Hi there.
Yes, I'm calling for my husband because I'm looking at my husband just barely walking. I mean, every step is getting short. And I just wanted to know what is it that we can do to help. He has been to several doctors. He has had shots in and out of his back. One doctor even said he was going to go in there and he was going to burn the nerves.
Yeah.
Every time he comes from the doctor, his pain gets worse and worse.
Right. So you mentioned two things that, as far as his problems, and one is him moving or functioning. So the walking could be from the nerve compression, and generally if it's a nerve problem that's affecting their walking, you probably need to take pressure off the nerves. But again, you can do that through much smaller incisions nowadays and recover a lot more quickly, minimize the complications like infection and bleeding. But as far as the back pain, the burning procedure, there's the rhizotomy. It's similar to what I described in that video. But again, the more traditional approach is with the needle. You should expect about a year and a half relief max. I think with the camera, I'd expect much more long-term relief and more of a global plane relief because we can affect multiple nerves at a time.
Okay, that was a great question, Cynthia, and we hope your husband gets the the treatment and pain relief that he deserves. Well, doctor, this was a really great show. I want to thank you for being here. And for those of you who want to contact Dr. Rodriguez's office, you can call 504-620-5520. I'm Maria Muro, and I want to thank you for tuning in to Doctors New Orleans. Remember, if it's about health, we cover it, and we want to hear from you. Thank you for your calls tonight. We hope you found this show informative, educational, and inspirational. Stay healthy, and good night.